Going to give his senior presentation. He's from Okemos and Hope and MSU COM. I think I got that right. All right.
Yeah, nice.
And we're going to try it. We're hiring him for next year, so we are not getting rid of him. He's dumb enough to stay. So, welcome. He's talking about GBS. Go for it.
Thanks, Dr. Andrew. So, like Dr. Andrew said, I'm Jamieson. I'm a fourth-year PM&R resident here at Michigan State Sparrow, and today I'm going to be chatting about Guillain-Barré syndrome and electrodiagnostics, in particular related to that. So, to start, I'd like to reveal my disclosures. As a senior resident, you may imagine that I don't have many disclosures. So, my first disclosure is, despite my more formal topple, where my shirt is not tucked into my sweatpants, I am wearing sweatpants. Also, I recently have become the proud father of Violet, who's now 9 months old, and I have to disclose that I cannot have a conversation with anyone without showing off pictures of her. So if anyone logged on for just the Violet photos, you can mute me for the rest of the talk. You got your photos. She's much more exciting than me. And then even though Kansas State was a purple team, Violet was still upset following the recent MSU basketball loss in the Sweet 16. But other than that, I have no disclosures. So let's get into what we came here to talk about. So Guillain-Barré syndrome is the most common immune-mediated polyneuropathy. It's got multiple variants, and its most common is AADP. Today, I'd like to focus on GBS's history, what GBS is like today, its epidemiology, presentation, antecedent events with a special focus on vaccines, GBS and its subtypes with a focus on AADP, AMAN, and AMSAN, as well as pathophysiology related to those, pertaining mostly to those three, and then introduce this concept of reversible conduction failure. The bulk of the presentation will be about electrodiagnostic criteria for GBS. So we'll be talking about the current criteria, the history of the criteria, and the comparison of these criteria. And then we'll briefly touch on treatment, talk about some conclusions. I'm sure Andrew will find something to discuss. So let's start from the beginning with the French, as the name would imply. And so Guillain-Barré syndrome was first described by Auguste Chomel in 1828, followed by Jean-Baptiste Octave Landry, who described the first documented case of acute ascending paralysis in 1859, and concluded that the disease process was affecting the peripheral nerves. Back then, the treatment was quite rudimentary. It included chloroform, turpentine, quinine, electrical stimulation, opium, pork chops, and wine. A little bit different than what we have today. In 1916, neurologists Guillain-Barré famously admitted 2 patients to an army hospital with motor difficulties, areflexia, and paresthesias. One of their key historical findings noted was the CSF on these patients. The lumbar puncture was a pretty novel procedure at that time, and they noted the phenomenon albinocytological dissociation, which is the increase in albumin with the absence of lymphocyte elevation. And so this is one of the most all-time important findings of the diagnosis of GBS and is still used today. So great. The history must stop there. We found Guillain-Barré, and we're here to talk about Guillain-Barré syndrome. But let me introduce you to a third physician in play at the time of this famous discovery. So André Stroll. André Stroll was also a French physician, served as a radiologist in World War I, where he met Guillain-Barré. He contributed to the study of the reflexes and nerve conduction studies of the 2 patients described in this seminal paper that he authored with them. However, his name was controversially omitted as the third author behind Guillain-Barré. There are a couple theories as to why his name was omitted. Mainly his contributions were electrodiagnostic related and didn't really revolve around the CSF analysis. And he also lost touch with Guillain-Barré, who worked together later on multiple papers. Stroll was also young at the time. He had only been practicing for 3 years. So a few different reasons why his name was omitted. Stroll passed away in 1977, and his obituary notice refers to the syndrome as Guillain, Stroll, and Barré. Food for thought. So what did André Stroll do to help quantify GBS back in 1916? So there's been a little bit of misunderstanding about the certain type of electrophysiological studies that was conducted in the original paper, but I'll do my best to describe what's known in the history books. So Stroll's electrodiagnostic work revolved around this myographic study, which examined the abnormalities of a tendon reflex in the first two patients. And so Stroll examined the timing of the muscle tendon excitation, which was registered with the help of this apparatus with a great name, Signal de Desperez. And essentially this device was a rudimentary pressure gauge attached to a recording cylinder, a chronograph. And to my understanding, there was no needle used for this apparatus. And so Stroll recorded the latencies from when he percussed the Achilles reflex while recording over the gastroc. And there was commonly three waveforms. The first, the mechanical jerk, then second, an idiopathic muscle contraction, and then third, the longest latency of the three was this reflex contraction. And Stroll noted that the registered reflex contractions were very weak with a delayed onset and sometimes abnormally absent in these first two patients with Guillain-Barré syndrome compared to a normal subject. And so the original findings from this myographic study led the authors to conclude that the pathophysiology was related to the disruption of the central part of the reflex arc, which isn't necessarily true, but at the time, the role of myelin in neurophysiology was still unknown at that time. But pretty cool stuff, the rudimentary stuff that they were doing over 100 years ago. So today, this is really similar to how an H reflex is completed, which is the analysis of an S1 reflex arc, which is, again, crazy that this is now still being used 100 years later. So the technique today is obviously modified, and we use electrical stimulation as opposed to mechanical percussion. And with the help of a couple additional transistors or two, compared to 1916, we can record it on a computer. This technique is still useful today for diagnosing GBS. So hopefully you found that as some interesting backstory to kick off our discussion of GBS. So today, acute mediated polyneuropathies are classified under the eponym of Guillain-Barré syndrome, after the aforementioned French author's early description of the disease, which were quite accurate and still hold true to today. GBS is one of the most common causes of acute acquired weakness and is often provoked by a preceding infection. GBS may be complicated in some cases, respiratory failure, autonomic dysfunction, and all myelinated nerves can be affected. GBS occurs worldwide with an overall incidence of 1 to 2 cases per 100,000. While all groups may be affected, the incident rate slightly increases with each 10-year increase in age beyond the first decade of life. There are some, as far as gender-specific rates, they're a little bit higher for males compared to females with a relative risk of 1.78. So if you're male, you're a little bit more likely to have GBS, and the older you get, you're a little bit more likely to have GBS. So what does GBS present with? So typical clinical features of GBS include a progressive and symmetric muscle weakness. Weakness can vary from a mild difficulty with walking to near complete paralysis of all limbs, facial, respiratory, and bulbar muscle, depending on the disease severity and the clinical subtype. Decreased or absent deep tendon reflexes in the arms or legs are found in approximately 90% of patients at presentation. Most patients will develop hyporeflexia as their symptoms worsen. Initial symptoms may become apparent within a few days to a week and typically progress over a period of 2 weeks. And usually by 4 weeks onset, more than 90% of patients have reached the nadir of their disease. Other clinical findings in patients with GBS include sensory impairment, an antecedent event, and sometimes dysautonomia, like we had mentioned. So antecedent events that happen before. So these events trigger an autoimmune reaction in GBS, and infection is a form of these events that can happen before. In some studies, up to 2/3 of patients give a history of respiratory or GI infection prior to onset of GBS. And Campylobacter is the most common culprit of this, identified in approximately 25% of patients. And there was a study in Sweden that had estimated that the risk of developing GBS during the 2 months following a symptomatic episode of Campylobacter raised your risk of GBS 100-fold higher than the risk comparatively to the general population. And then in regards to COVID-19, there have been several cases of para and post GBS associated with COVID-19 infections. However, a direct causation relationship has not yet been established. Also, it's kind of difficult to compare the numbers occurring during the pandemic because other infectious causes of flu or other viruses during quarantine were quite low. Kind of makes the analysis a little bit more difficult. Other notable viruses that could lead to GBS include CMV, influenza, and others. So, COVID-19 vaccination. While the public health emergency for the COVID-19 pandemic may be scheduled to end May 11th, 2023, a continued hot topic these days is vaccinations, specifically those related to COVID. And while this isn't like the heart of my presentation, I do think that it's important to stay properly informed regarding up-to-date COVID-19 vaccinations, recommendations, and investigations. And currently, there's an investigation regarding the potential relationship of GBS and the adenovirus vector vaccine administration, brand names under Johnson & Johnson, as well as AstraZeneca. And the CDC is currently monitoring multiple vaccine safety systems to determine if GBS is occurring more among those who are vaccinated compared to the background rate of GBS in the population. And so recent studies have found evidence suggesting an increased risk of GBS among adults 18 years or older after the J&J vaccine, but not after mRNA, Pfizer, and Moderna vaccines. And currently there's an observed 30 cases of GBS per 100,000 in J&J vaccinated, which is higher than the background rate of the 1 to 2 per 100,000, as we discussed earlier. And while the rates of GBS in mRNA vaccination populations are similar to background rates, suggesting that there's not a correlation, I do have to give a shout out to Dr. Kwa, who presented a case at AAPMR in 2022 in which a young patient developed severe AMAN 9 days following mRNA Moderna COVID-19 vaccination. And so Dr. Kwa diagnosed this patient with AMAN with EMG at Sparrow. And then I was fortunate enough to help rehab this patient over at Mary Free Grand Rapids while I was on away rotation and assist with writing up this case. And so this case, of course, is correlation, not necessarily causation, which is what the general population data would suggest. And this case was reported to the Vaccine Adverse Event Reporting System. So what's worse? Risk of GBS after COVID vaccine or after COVID infection. And there's been an observational study that's been completed that estimated approximately 38 excess cases of GBS per 10 million who received the adenovirus COVID vaccine, and 145 cases per 10 million after a positive COVID test. And so because of this, the CDC feels that the potential neurological risks following vaccine administration are less likely to occur than neurological complications following COVID infection, and therefore have continued to recommend COVID vaccination. Flu vaccine, just to touch on just a little bit, very similar to COVID vaccine. Essentially, there is some risk with increased risk of GBS with flu vaccine. It can vary season to season, but overall studies have suggested in the past that risk of GBS following flu infection is slightly higher than following flu vaccine administration. And so there's continued recommendation of flu vaccination. So let's get into the GBS subtype. So first up is AADP, and AADP is the most common form of GBS in the United States and Europe, and represents approximately 85 to 90% of cases. And typical clinical features are progressive, symmetrical muscle weakness, accompanied by absent or deep tendon reflexes. This is sometimes used synonymously with GBS, even though it is technically a subtype of GBS. Just because it's a rectangle, it doesn't mean it's automatically a square or something like that. AMAN and AMSAN are primary axonal forms of GBS with or without sensory involvement, respectively. And these forms are frequently observed elsewhere in the world, like China, Japan, and Mexico. But they also compromise an estimated 5 to 10% of GBS cases in the United States. Clinically, these patients can appear similar to AADP patients, but can progress more rapidly, sometimes have preserved deep tendon reflexes, and have incomplete recovery. Variant forms of GBS are characterized by clinical features of ophthalmoplegia and ataxia rather than limb weakness, and are frequently associated with antibodies against GQ1B, which is a component of oculomotor nerve myelin. And these variant forms may be called anti-GQ1B syndromes and include Miller-Fisher syndrome, Bickerstaff brainstem encephalitis, and PCB. Their pathology appears to be chiefly secondary to demyelination, but isn't as well understood. We'll spend a little bit less time on these variants today during presentation, but briefly review their clinical features. So Miller-Fisher is the most common of these less common subtypes, and is typical to present with its classic triad of ophthalmoplegia, ataxia, and areflexia. About 1/4 of patients who present with Miller-Fisher syndrome do have some limb weakness as well. Bickerstaff brainstem encephalitis is another GQ1B variant of GBS, which is characterized by encephalopathy, ophthalmoplegia, and ataxia. Patients sometimes have facial weakness with bulbar symptoms, mild weakness, and sometimes normal or brisk reflexes. And PCB is also a subvariant of this type, characterized by oropharyngeal, neck, shoulder, and muscle weakness with swallowing dysfunction and possible facial weakness. Usually leg strength and reflexes are preserved with this less common subtype. And then there are a couple other rare variants that can occur as well, but today we'll be focusing more on the subtypes of GBS while highlighting AIDP. So as far as temporal continuum between AIDP and CITB, AIDP is a monophasic subacute illness that typically reaches its nadir within 2 to 4 weeks. Some authors use the terms subacute inflammatory demyelinating polyneuropathy, or AICDP, to describe the nadir achieved between 4 and 8 weeks. And then CIDP continues to progress or relapses for greater than 8 weeks. And so there's kind of like this arbitrary clinical temporal delineation between AIDP and CIDP that can be difficult to ascertain in practice. An examination over time and serial electrodiagnostic studies can help clarify whether this clinical course is that of AIDP or CIDP. And usually, to kind of compare and contrast from one another, GBS usually has an onset that's more easily identified, whereas CIDP onset can be less precise and can be unclear. Antecedent events are usually well described in AIDP cases as opposed to in CIDP cases. CIDP frequently has relapsing features more than 3 times, and some AIDP patients will develop chronic relapsing weakness similar to CIDP. CIDP also has subvariants as well, including MADSAM, but today we'll be focusing on GBS and the particular subtypes AIDP, AMAN, and AMSAN. So let's talk about how this works. So GBS pathology varies depending on its subtype. So AIDP starts as an inflammatory response, usually following a defined antecedent event, and the body's immune reaction causes this anti-ganglioside antibodies to attack the nerves. In an AIDP, that attacks myelinated nerves. The myelin loss leads to a non-uniform conduction block, which leads to slowing and muscle weakness. Conduction block is when saltatory conduction along the axon is stopped, but the axon remains intact. And so this electrical current becomes insufficient to depolarize the node to a threshold, resulting in conduction failure or block. And so conduction velocity can be reduced and temporal dispersion can be caused. So overall, don't forget the name because it'll help you out. So acute happens quickly, inflammatory, immune mediated, demyelinating affects myelinated nerves, polyneuropathy attacks myelinated nerves in a non-uniform manner. And it should also be noted that axonal degeneration can occur as a secondary bystander response from this demyelination process. And it's also been proposed that Miller-Fisher syndrome and some of the other kind of cousins variants can share some similarities to this pathophysiology described here of AIDP. Another form of GBS is axonal in nature, so acute motor axonal neuropathy, and if you sub in sensory, acute motor and sensory axonal neuropathy. And in these subtypes of GBS, an antibody and complement-mediated response occurs at the axon level, specifically the nodes of Ranvier between the myelin portions, which lead to a direct axonal lemma injury and nerve dysfunction. And either direct axonal injury can occur or conduction block can result by perinodal myelin detachment and node lengthening membrane channel dysfunction. And so this conduction block can rapidly reverse in some cases, otherwise known as reversible conduction failure, a little bit more on that later, or it may progress to direct axonal degeneration in others. Marked axonal degeneration can cause delayed and incomplete motor recovery. The motor nerves that are affected in AMAN include the ventral roots, peripheral nerve, preterminal intramuscular motor twigs, and then in the motor sensory variant, it can also include sensory nerves as well. And so these axonal forms are relatively uncommon in the United States, but are more frequent in Asia. The development of AMAN has been associated with certain specific IgG antibodies to certain gangliosides, which are present in peripheral nerve axons. And these certain anti-ganglioside antibodies listed here have been observed following Campylobacter infections. Each specific antibody can result in varying pathophysiology and severity. And antibodies that are derived from Campylobacter, specifically as depicted here, usually result in this axonal form. So what's this asterisk RCF? So reversible conduction failure is when there's a conduction loss or failure followed by rapid recovery. So on initial nerve conduction stimulation, conduction failure can appear very similarly to conduction block. And so there's this concept of nodopathy, which has been suggested to explain rapid reversal that occurs in some AMAN or even some AIDP cases in which conduction velocities, F waves, and CMAP amplitudes without temporal dispersion have improved without time for real remyelination to occur. And so this process of nodal dysfunction followed by rapid recovery has been hypothesized by an antibody complement mediated attack to the nodal axonal lemma, which induces nerve conduction failure. But if that autoimmune attack is aborted, then axonal degeneration does not progress and the nodal function rapidly recovers, hence this reversible conduction failure. And so here's an example of RCFs, which was noted in an observational study. And there's evidence of conduction block on the first studies, 10 days following symptom onset on the fibular nerve on the left and the right, pictured up here. And the proximal CMAP to distal CMAP amplitude ratios are 0.53 and 0.66 in the left and the right and left fibular nerves. And then this patient underwent IVIG and had improved CMAP amplitudes only 20 days following from the previous study. And so this change is described as reversible conduction failure. And we should know that there's no evidence of temporal dispersion on this repeat study, which would be indicative of a demyelinating process, not reversible conduction failure. And so on the contrary, remyelination following acute demyelination or ongoing demyelination is characterized by this desynchronization of conduction among fibers, which induces this process called temporal dispersion, which decreases CMAP amplitude due to the cancellation effect of opposing phases of a single motor unit potential. And so this decrease is similar in amplitude size proximally and distally, which can falsely improve CMAP ratios, but shouldn't be confused with RCF. So how should we go about diagnosing GBS? We know a little bit about the pathophysiologies and the subtypes. And then how is EMG incorporated on top of all of this? So first, I want to take a look at the Brighton criteria, which were referenced the most frequently during my literature dive into GBS. So let's take a look at the Brighton criteria. The Brighton criteria are intended and validated for typical presentations of GBS and Miller-Fisher syndrome, and were developed in 2011 alongside the CDC with the intention of better defining diagnostic criteria when reviewing adverse outcome reactions after vaccine administration to quantify the level of certainty of GBS diagnosis. And so rare variant forms are not necessarily intended to be used for the Brighton criteria. And then we should note that these criteria were developed for retrospective epidemiological and vaccine safety studies, not clinical practice. So this isn't something that we could use for clinical practice per se. So Brighton criteria is divided into 5 levels of certainty. So we'll focus on the top 3 levels of certainty. And essentially the criteria require a patient to have classical clinical symptoms of GBS or AADP, and both EDX and LP findings suggestive of the disease, which would represent level 1 certainty of GBS diagnosis. And so level 2 includes abnormalities in only one of these with the LP findings or the EDX findings, while still fulfilling all clinical history and physical criteria. Level 3 only has the clinical history and physical criteria, but does not include EDX findings or LP findings. And so lower level of certainty, and then level 4 and 5 are described to meet essentially cases that don't meet these above criteria. So getting into the nitty-gritty details of what specific criteria Brighton used in the retrospective analysis that count as positive studies indicative of GBS, specifically for the electrodiagnostic criteria. And so the Brighton criteria used Hughes and Kornblath criteria from a study in 2005, which described subtypes for GBS, AADP, and AMAN and AMSAN specifically. So for AADP, the focus of EDX surrounds demyelinating findings, which include slow conduction velocity, slowed onset motor latency, conduction block as defined by certain ratios of proximal and distal CMAPs, and then a delay in F-wave response latencies. And so these are based on a percentage of normal values. And then AMSAN and AMAN are defined separately and so they can meet this criteria as long as there's no demyelinating features as from above, except for one allowed feature with an overall decrease in distal CMAP. If only AMAN, and then if there's SNAPs involved, then it would be AMSAN. And so, as you may guess, there are some problems with this certain set of criteria that are suggested by Hughes and Kornblath, and its subtypes. So inferring percentages of normal nerve conduction studies are tricky because most labs have varying EDX machine setups. And varying lab normal values. And so this percentage approach doesn't take into consideration various nerves that may obviously be physiologically different from each other, such as the tibial nerve or the ulnar nerve. And it also doesn't take into account other pathological processes that could be coinciding at the same time, which could mimic these findings. Ticks and fleas, I think that might be a saying someone said. And so there's some holes in these criteria from Hughes and Kornblath for the EDX of GBS. So that's what one criteria has to say. So let's take a look at other criteria. Let's see if there's a gold standard. So let's take a look at the history of GBS diagnosis criteria. So the electrophysiology characteristics of GBS were first described in 1978, and then clear cutoffs were first proposed by Albers in 85. So Albers described only findings of AADP. So Albers criteria required 2 nerves to include at least one of the following features for diagnosis: conduction velocity slowing, prolonged distal motor latency, temporal dispersion, and then F-wave slowing. Looking more closely, Albers has cutoff criteria for CV slowing, but they mentioned that a 5% decrease from lower limit of normal would be counted as abnormal. That seems pretty sensitive. Prolonged distal motor latency, also, again, only a 10% increase. That could be quite sensitive as well. Temporal dispersion, okay, that wasn't discussed in the Brighton criteria. And then there's F-wave slowing of 120% or more. Okay, so that's the same. But there's no mention of conduction block. Okay, wait. So I looked for another source that was citing the Albers criteria, but this looks different. So let's take a look at this. So yep, we got prolonged distal latencies again, different percentages, conduction velocity slowing there, different percentages, prolonged F waves. Yep, there again, but that's not 125% as opposed to the 120% from before. We also have temporal dispersion is also there, but then they added conduction block as a criteria, which wasn't listed in the other source. So there's some obvious discrepancies here in the literature. But this is from 1985. So surely there's something that's more easily defined and synonymous in the literature, right? Even Dr. Andary is laughing because he knows it's not right. So while the Albers criteria had focused on the AADP subtype diagnosis of GBS, others wanted to include and define other emerging subtypes. So following the development of the 1985 Albers criteria, there were some noticeable similarities in presentations of patients in China with variation in electrophysiological studies. So Ho attempted to modify the Albers criteria to include diagnosis of axonal forms of GBS and AMAN, which was the most common form noted outside of the United States and Europe at that time. So Ho's electrodiagnostic definition of AMAN stated that there would be a decrease in CMAP, and it would be in at least 2 nerves without evidence of demyelination as defined by Albers criteria. The additional criteria of AMAN was the only noted difference between Ho and the previously defined Albers. He didn't touch Albers' AADP criteria. So next, Hayden in 1998 basically took Ho's criteria and modified it to include conduction block as opposed to temporal dispersion, which was removed from the AADP criteria. So only a small change was made here, but there's an express difference of principles that's noted. So Hayden placed more of an emphasis on conduction block as opposed to temporal dispersion, as previously noted by Ho and Albers. So both Ho and Hayden have been referenced as the most widely used criteria for the electrophysiological classifications of GBS. And yet there's a widely accepted textbook from Preston and Shapiro that references that image that I showed you, the modified Albers criteria, then the Brighton folks reference Kornblath and Hughes. So what's going on so far? So this is madness. Surely it could be more congruent or simpler. Wrong. So Rajabali came about in 2015, and these criteria were attempted to subcategorize Hayden's AADP and AMAN criteria with more stringent cutoffs of conduction velocity slowing and distal motor latencies. The same qualifying rules for number of nerves requiring certain features remained identical, but the qualifying manner of how these nerves can qualify changed. So it's just an odd syntax change and definition, which is confusing. And so these criteria note that F-wave absence in two nerves with additional evidence of slowing of conduction velocity of distal motor latency could qualify a patient for AADP diagnosis. So Rajabali, who attempted to further define more specific anatomic conduction block criteria, noted that a 30% conduction block, excluding the tibial nerve and two nerves with the additional F-wave or slowing of CV, conduction velocity or distal motor latency would qualify a patient for AADP diagnosis. And so for AMAN diagnosis, using the Rajabali criteria, there was continued requirements of the demyelination with a decrease in CMAP of the lower limit of normal and two nerves. And there was new qualifying inclusions of affected nerves under AMAN, which were F-wave absence, conduction block, or one of both, in addition to reduced distal CMAPs. So something seemed similar there, right? So let's back up. So it seems that AMAN has some overlapping qualities according to this Rajabali criteria, and that's because they do. So overall, F-wave absence and conduction block are both contributing criteria for either AADP and AMAN. And this inclusion of conduction block under AMAN diagnosis was newly adapted in this Rajabali criteria based on realizations that conduction block is a part of the pathophysiology of AMAN sometimes, as we had previously discussed. And the key differences between AADP and AMAN, according to Rajabali, are based on the presence or absence of demyelinating features, which are defined in this purple box here. So that's slowing. So slowed conduction velocity, slowing of distal motor latency, and slowing of F waves. Overwhelmed yet? Yeah, me too. So then in 2017, Unsini described criteria that preferred temporal dispersion over conduction block when diagnosing AADP in comparison to the Rajabali criteria. So this is noted on 3 and 4 here. So this is similar to the kind of discrepancy we had noticed with Ho and Hayden, excluding temporal dispersion versus conduction block and including the other. And so Unsini suggested that temporal dispersion helps to distinguish conduction block and demyelinating neuropathy from conduction failure nodopathy of AMAN, and therefore preferred including temporal dispersion criteria in AMAN, or excuse me, in AADP. And so there is also a noted inclusion of abnormal sensory findings with sparing of the sural nerve here as well. And then there's a different percentage cutoff for the distal motor latency highlighted there. And so Unsini criteria for AMAN are essentially the same when compared to Rajabali. However, the phrasing and inclusion, again, changes, which is slightly different and confusing again. And so this allowed exception of demyelination also has an increased cutoff of distal CMAP. So nothing too exciting here so far, but there is continued thought that conduction block and F-wave absence could be indicative of AMAN. And so by taking conduction block out of the AADP subtype diagnosis criteria from before, and only including temporal dispersion as a slowing criteria, Unsini is placing more of an emphasis on speed when defining AADP as opposed to amplitude drop or conduction block for subtyping. Unsini also placed emphasis on the importance of serial studies with assistance from assisting the subtype definition of AMAN. Unsini felt that some cases that appeared to be demyelinating on initial studies with evidence of conduction block and slowing would rapidly improve. And so these cases were likely AMAN with RCF here on the right, or possibly even AADP with RCF. So these criteria on a second follow-up EMG further help define those patients' pathophysiology. AMAN with RCF based on criteria definition is an increase in CMAPs, as we saw in that example from before, without temporal dispersion, as well as conduction block reversal and the revival of F waves that were previously absent. And so on the left, on serial studies, they again define classical continued axonal degeneration with persistent reduced distal CMAP comparatively. And so subsequently, there may be a disappearing of what may have fit under conduction block as a criteria, but was in fact early onset axonal changes that have gotten worse and no longer fit the conduction block criteria. Also noting that there is not temporal dispersion, which could also cause the defined conduction block to disappear. The empathy criteria was the most recent set of criteria that I could find in the literature, which, takes a somewhat different approach to defining GBS, and that there aren't any subtype categories attempted to be defined here. And so instead of this rather simple set of specific, instead it's a rather simple set of specific nerve conduction studies changes that should be present in 2 motor nerves for definite GBS. So there are specific changes as far as slowing or amplitude changes for some of the listed categories are not well defined. They do define temporal dispersion and conduction block. And this is a different approach when compared to the other criteria, which include specific cutoffs for each of these different changes. And so it might seem less descriptive, but after reviewing and comparing all these different criteria, it's actually kind of somewhat refreshing to leave interpretation of its slowed conduction velocity or increased F-wave latency up to the provider who is performing the test with their specific machinery, lab-specific normal values, and if you happen to correct for patient age or temperature, et cetera, something like that. And so it should also be noted that probable and possible categories also include sensory nerve changes outside of the sural nerve as possible contributing criteria, which was a focus of this study that they wanted to emphasize. So what should we conclude from this exhausting list of somewhat overlapping, somewhat exclusive criteria when approaching EDX studies for diagnosis? If you knew less than you did before coming into this, I apologize. I'll try to wrap it up. So while I believe, along with others, that there's a lack of congruent of EDX criteria for GBS and its subtypes. And so I think that you would agree after falling asleep during the middle of Hayden criteria breakdown of 5 criteria ago. And that because of this incongruence, I believe that defined criteria or portions of the defined criteria should be used in conjunction with clinical reasoning where appropriate. Because if you don't use these criteria reasonably so, they can quickly betray you. For example, if you were to apply the empathy criteria to this case, in which 2 motor nerves met criteria for GBS by way of increased distal latency to motor APB and slowing of conduction velocity with conduction block to the ulnar nerve, then this patient has GBS instead of moderate carpal tunnel with ulnar neuropathy at the elbow. And so we should always consider the possibility that EDX abnormalities detected in a patient are not necessarily a consequence of the disease under scrutiny. And this is especially important when getting lost with all these different GBS EDX criteria. When you get in the weeds, you still got to focus on the forest as well. And so because there are many faults, in the current GBS criteria landscape without a uniform approach, I suggest that we utilize multiple criteria and clinical reasoning to best approach each possible GBS patient. So for example, we should be utilizing clinical criteria from our history and physical to assist with diagnosis such as weakness, absent reflexes, monophasic illness with symptoms present for less than 4 weeks, to name a few, and then other classic symptoms of atypical variant symptom subvariants can be used on history and physical exam to assist with assessment as well. And then additionally, EDX along with CSF analysis are crucial in an evaluation of GBS. And then also autoantibody testing is an emerging field that could be utilized if appropriate and if available. And then more specifically for EDX evaluation of specific subtypes of AADP, AMSAN, and AMAN, it should be noted that there are potentially possibly overlapping features of the GBS subtypes, which include absent F waves and conduction block during the early disease process. And something that wasn't included from before was that there might be some late wave responses that could be overlapping features of the AADP and AMAN, which are A waves and repeater F waves, could be overlapping features. As far as differentiating features of AADP and from demyelination and axonal, they primarily revolve around these principles of demyelination and axonal changes. And so referencing multiple criteria as mentioned before, demyelinating features revolve around slowing. So slowing of conduction velocity, slowing of distal motor latency, temporal dispersion, and then slowing of F waves. And then something that's not mentioned by any of the previous studies or the previous criteria is the H reflex, lest we forget about the signal de Desperez, where it all started with Stroll. So this H reflex has been referenced as one of the most sensitive findings in some studies of GBS early on in the disease process, and yet no one mentions it in their diagnostic criteria. On the right, specific axonal changes could include the absence of those demyelinating features in the purple box over here, with possibly one exception, and then decrease in overall CMAPs and SNAPs with sterile sparing. You could also have absence of H reflex, I suppose, as well. And then something that's so obviously missing again from the diagnostic criteria are any changes that occur on needle EMG. And so axonal changes in AMAN can present from primary axon loss as a result of axonal lemma injury from the anti-ganglioside attack present in AMAN and AMSAN. And these changes can be seen needle EMG as perfuse fibrillations and reduced recruitment, which can help confirm systemic axonal injury. And then similarly, axon changes can or don't necessarily have to be noted in AADP as secondary axonal change. And then lastly, reversible conduction failure can be noted on follow-up EDX studies, which can help further classify axonal variants with an improvement of CMAPs and revival of F waves with normal latencies. And so reversible conduction failure is classically associated with AMAN, but it can be seen in cases of AADP. Very briefly, this was kind of the climax of the presentation, but very briefly, I do want to mention Miller-Fisher syndrome, which is the most common remaining of the uncommon subtypes to discuss. And so essentially, EDX purpose and use is not well understood for a multitude of reasons. Specifically, there's been variable peripheral nerve abnormalities or lack thereof in the reported literature in regards to how Miller-Fisher occurs. Some of the pathophysiology is still not well understood. And therefore, some patients could have with Miller-Fisher could have some findings similar to AADP, which could help. But at this point, it doesn't seem like we're quite sure in the literature at this point. And then EMG in regards to blink reflex could be helpful in diagnosis of Miller-Fisher syndrome, according to some studies. But it's, again, not quite certain. And then with needle EMG, there have been some studies that have proposed that you're more likely to find abnormalities in facial muscle compared to peripheral muscles. Obviously, going down that sort of path could be patient and provider dependent. And so again, some of the literature revolving around EDX purpose of diagnosis of Miller-Fisher syndrome is still kind of up in the air. So if EMG is ordered for a patient, what's the typical approach that you take with the test? And so typically, at least 3 sensory nerves are recommended. There was kind of a variety of how many motor nerves to include, but it seemed that around 3 to 4 motor nerves, all with F waves, should be included, and then a bilateral H wave as well as needle EMG. And then when should it be ordered is also a topic of discussion. And it should be noted that there have been some observational studies that have shown that EDX abnormalities in 37% of 71 patients found abnormalities as early as 4 days from symptom onset. But most abnormal findings of EDX are typically most pronounced at 3 to 4 weeks from symptom onset. And then what does this impact? So this impacts diagnosis, subtype diagnosis, and prognostication. It can help direct treatment plan, and it can help rule out other differentials on the differential diagnosis list. And then briefly, I wanted to talk about treatment, but I'll leave this mostly to the neurologist. IVIG is generally better tolerated and easier to administer compared to Plex. Both improve patient outcomes. Some studies have showed that they have noted equivalent efficacy, and they've been proven to improve muscle strength, reduce need for mechanical ventilation. Steroids used to be used in the past, but less so now. They've fallen out of favor. So what should we conclude? So overall, there's incongruence of EDX criteria for GBS and its subtypes. And therefore we should be using clinical criteria as long with electrodiagnostic studies and LP findings, as well as autoantibody testing when appropriate, to better impact diagnosis, subtype diagnosis, prognostication, direct treatment plan, and rule out other differential diagnosis to improve in patient outcome. And I buzzed through that, and I was miraculously never interrupted by Dr. Andary. I saw him writing some things down, so I'm guessing that we'll have a couple things to discuss here. Yeah, thanks for your time, you guys.
Dr. Haak, that was great. I gotta say, holy moly. Yes, good job. Even Dr. Kaufman's clapping there. So anybody got, you did a lot there. I could make comments, but I guess I'd rather take questions. Dr. Kaufman.
So, Dr. Haak, terrific at multiple levels. One of the more interesting statements that I've learned from Miller Fisher.
Okay.
Miller Fisher once said the following: never allow the laboratory or technology to lead you around by the nose. That is a direct from Miller Fisher. And what that means to me is, at least when he was enunciating that, was EMGs are extremely important to confirm that it's a clinical diagnosis. Even his own syndrome is a clinical diagnosis that you want to confirm. If the EMG doesn't confirm, it doesn't eliminate the disease. If technology takes you in a different direction than the clinical history and clinical examination, re-examine the patient, re-examine them. EMG as a confirmatory measure is central to neurology. We're very fortunate to have a sister relationship and trust with our sisters and brothers in PM&R. But the people listening need to understand, if it doesn't correlate, it doesn't mean there is no disease. I just wanted to highlight that point.
Can I tell a story, Tyson? Just when I was much younger and still afraid of Dr. Kaufman, we were in the ICU together. I was doing the EMGs, and this person was on a vent and paralyzed. And at the end of the day, having had Miller Fisher, but I couldn't find clear-cut abnormality, except finally we got the blink. And the blink was very slow and clearly abnormal. And I remember we gave each other a look like, okay, we can treat this person like it's GBS. Even though clinically, he looked at me, he goes, I know this person has GBS, and I'm going, I can't find anything. So working together and not being a slave to the tests, I agree with you, Dr. Kaufman. But I've been just as nervous as you young guys and residents with Dr. Kaufman.
Oh man, Mike, come on.
We're colleagues, and we both try hard, don't we? Tyson.
Well, I guess I would emphasize that the guidelines seem to always say that the electrodiagnostic evidence should be consistent with, and normal findings or near normal findings can be consistent with these syndromes. But that's a side point, I guess. Dr. Haak, as you breezed through the cavalcade of different sets of criteria, did any of these authors perform sensitivity specificity analyses about their particular criteria, like area under the curve type of things, or are we in the dark in terms of the trade-offs?
I think we're in the dark. That's why there's a lack of congruence.
Yeah, they did not do receiver operating curve, trying to decide what your gold standard is or reference standard. Multiple areas, Tyson, this is not good evidence-based stuff. Yeah. And at the end of the day, Albers, was one of the first guys who came out of it. For those of you who know, he's from the dreaded University of Michigan, but he's great because his kid played hockey for Michigan State. And his criteria is almost as good, but he ignored the problem of the fibular nerve and the tibial nerve having almost everybody in the population met his criteria for AIDP. So the early criteria, Haak, you did a great job on this. But later criteria are the only people who really differentiated the fibular and tibial. So it's not good evidence-based, Tyson, in my opinion.
Oh, you're muted, Dr. Andrew.
Sorry, we're getting near the end here. Anybody else got questions or comments?
How about a round for Mike? Maybe getting people to unmute.
More
and
violent
round.
pictures would be good.
What? 14 of them isn't enough?
Less
All right.
caution and Andy, more violent. That's what I would say.